to start our hot topic session on neuroradiology of the head and neck. We have three extremely distinguished speakers, and our first speaker is my friend and the current chair of the American College of Radiology, Dr. JACQUELINE BELLO, who is also a past president of the American Society of Neuroradiology. Dr. Bello.
Thank you, Dr. McGinty. Thank you to the course organizers and the sponsors. Thank you for attending as well. So today's topic is going to be neoplasm or not. I have no disclosures, and I like this saying that if the human brain were so simple that we could understand it, we would be so simple that we wouldn't or couldn't. We're going to discuss an approach to correct diagnosis, looking at principles, pitfalls, and progress. And under principles, look at location, signal, edema, contrast enhancement, other findings present, and of course, the history. Pitfalls, mistakes not to make. Don't go there. Again, pay attention to signal, contrast enhancement, if it was given, mimics and artifacts, and then progress. We are going to look at some advanced imaging techniques. Today we will look at perfusion and spectroscopy. These that you've been seeing have always been two different patients, although each case looks alike. We're going to look at the cases and turn them into a lecture. The objectives will be to characterize brain lesions by using some advanced imaging, relate the lesion spectral patterns to their malignant potential, and to recognize different perfusion patterns to differentiate malignancy from other lesions and benign from malignant lesions. So let's start with this case, a 40-year-old woman who had no past medical history at all, and she presented with a seizure. You have diffusion imaging on the top left and T2 and gradient imaging before you. So what is the differential diagnosis? Abscess, tumor, tumefactive demyelination, a resolving hematoma, or infarct? You have a moment to think, and here's the answer. This is a resolving hematoma. So the pitfall here, the first images I showed you, the image on the left, those of you who said tumefactive demyelination, maybe you thought this was contrast with an incomplete ring. This was non-contrast, and with gadolinium, you see more complete enhancement. So what is T1 signal that is hyperintense? Contrast, of course, other paramagnetic substances, fat, subacute hemorrhage, whether early or late, and high protein. We must remember that also certain hydration states of calcium can demonstrate high signal on T1. So what were the clues to this case? There was blooming on the gradient image, as you see, top image on the right. And I didn't show you the susceptibility images on the lower portion of the screen, but you might appreciate both the susceptibility and prominent vessels. Here's the angiogram demonstrating the cause of that hematoma, and you see an AVM supplied by the middle cerebral artery and being drained by the vein of Labbe. Our second case, a 22-year-old male with a headache. Now we know to differentiate T1 with and without contrast. We have a ring-enhancing lesion. We look at T2, Gradient, this time no blooming, and we see a flare image on the bottom right. What is the differential diagnosis? Pay attention to the diffusion imaging and the ADC map. It's the same differential, and this time we will reach the correct diagnosis of an abscess. So what were the clues to this case? We have restricted diffusion confirmed with the ADC, low signal, and on additional images, we see a connection to the frontal sinus as the source for this intracranial abscess. Remember that there are diploic veins in the frontal region that are the etiology for such frontal abscesses in the setting of sinusitis. So, what is the differential diagnosis for restricted diffusion? Well, probably its most frequent use is in acute ischemia. Also, the active or acute lesions in MS may demonstrate restriction. Any viscous fluid, pus, resolving hematoma, mucinous cysts. Also epidermoids. This is our favorite way of differentiating them from arachnoid cysts in the posterior fossa. And then hypercellularity of tumors restricts the diffusion between the cells, such as lymphoma. So let's look at some companion cases. These are two different patients, top and bottom, with ring-enhancing lesions on T1 gadolinium studies. The top patient demonstrates restricted diffusion on the ADC map. The lower patient does not demonstrate restricted diffusion. The top patient also shows very few neuronal markers and acetate and alanine peaks, as well as a lipid and lactate peak. So the top patient with diffusion restriction and some amino acids prominent as well as lactate has an abscess, and the lower patient, a metastatic lesion. Two additional companion cases. Again, you see gadolinium enhancement and then a coronal T2 for each patient. Looking at the top patient, again, there is restricted diffusion, and on the spectroscopy, we again see amino acids that come early in the spectrum. So the top case is again an abscess. The bottom case, which looks strikingly similar, including the daughter cystic lesion, actually represents a glioblastoma. Our third case, a 55-year-old male with headache. T1's MRI pre and post gadolinium on your top left. The lower images are T2 and gradient imaging. Again, we don't see any blooming on the gradient. The lesion itself is rather low signal on the T2 study. So what's the differential diagnosis here? First, we will look at the diffusion imaging. No restriction, confirmed on ADC. So the differential would include lymphoma and TB, both low signal on T2. Is this tumefactive myelination, a resolving hematoma, or an infarct? This is a case of tuberculosis. And you'll remember that both TB and fungal disease, even though infection may not restrict on diffusion-weighted imaging. So the clues to this case were the low signal on T2 without any blooming to suggest hemorrhagic components. No restriction typical of TB, as well as some fungal disease. And the enhancement pattern, of course, rim enhancement. So what is the differential diagnosis for T2 hypointense signal? Well, some of the things that we've already spoken about. Hypercellular lesions, such as lymphoma, high protein content in lesions, certain infections, as we've mentioned, and certain stages of hemorrhage, the acute stage, early subacute, and chronic stages. Calcium, typically low signal, and blood flow. Here's a companion case in the posterior fossa with low T2 signal in the lesion itself. We do have some blooming on the gradient image. We don't really have diffusion restriction demonstrating. Pay close attention. There's a clue to the diagnosis on these images. I'll give you another second, but then we're going to give it away. So this 50-year-old male had a history of alcoholism and dysmetria. T1 pre, gadolinium is upper. T1 post, gadolinium. Those of you who missed the clue the first time perhaps now appreciate the empty delta sign in the patient's right lateral sinus, so that the low signal is hemorrhagic venous infarct, and it's due to sinus thrombosis. So I had shown you the T2 and the gradient image, and this was the clue on those images that there was sinus thrombosis accounting for the hemorrhagic lesion. In a companion case, we said hypercellularity can be low signal on T2 imaging. We have restriction of diffusion by DWI and the ADC maps. When we give contrast, we have a deep enhancing lesion, and this in a 43-year-old male with HIV and headache is, of course, lymphoma. A companion case demonstrates density on CT, contrast enhancement. Look carefully. Remember that hypercellular lesions can be dense on CT, but this is quite dense. Pay attention to the contrast. T2 gives the lesion away, a popcorn appearance, hemorrhage of different stages. The gradient echo scan shows blooming, and this is a cavernous malformation. Why did I tell you to pay attention to the enhanced image? You see an associated developmental venous anomaly, so typical of these lesions when they occur intracranially. Case 4 and case 5 are presented here, looking strikingly similar. Case number 4, a 29-year-old woman with a focal motor weakness. Case 5, a 13-year-old with a new onset of seizures. This is case 4, flare imaging, T2, T1, pre and post contrast. Look at the pattern of enhancement on the T1 contrast exam. Now look at some spectroscopy with me. We will first look at the normal side, and we will remember the typical pattern of choline, creatine, and then the NAA peak, the neuronal marker, at 2 parts per million. Choline, creatine, NAA, normal spectrum, normal side. Now let's look at the lesion. Choline much higher than creatine. Choline is a marker for cell turnover. NAA decreased, loss of neuronal elements. And we have an inverted peak at 1.3 parts per million using a TE, pay attention, of 144. An inverted double peak at 1.3 parts per million is lactate. So put this together with high membrane turnover, loss of neuronal elements, and necrosis. We'll get to the diagnosis. But first, let's confirm that lactate peak. We now use a TE of 35, and the doublet that was at 1.3 parts per million comes above the baseline. So this is lactate, representing necrosis. All of these elements add up to only one of these possibilities, and it is tumefactive demyelination. The principles here are very practical points. This was a white matter lesion. There was no central restriction on diffusion. The enhancement shows an incomplete ring. How about additional findings, such as the periventricular lesions oriented perpendicular to the ventricles, as well as a lesion in the same patient in the cervical spine, who had multiple prior sensory episodes of symptoms. So, of course, this is tumefactive demyelination. Now, we did say that MS can restrict, but we said it would be the active leading edge of demyelination. So if anything would have restricted here, it would have been the enhancing ring only. As a companion case, we again see a mass-like lesion, an incomplete ring, but doing perfusion imaging, where we would expect a neoplasm to enhance with increased perfusion, particularly if malignant, we see low perfusion, typical in MS, tumefactive MS. The companion case to that was the 13-year-old who had a new onset of seizures, also with a right frontal lesion. Not much enhancement after gadolinium is given, and really just some peripheral restriction of diffusion if confirmed by ADC. Well, let's look at some spectroscopy here, again at a TE of 144. We see a high choline peak, membrane turnover, relative to the creatine. We see a very low NAA peak, and at 1.3 parts per million, we have the doublet inverted at a TE of 144, suggesting necrosis. Now we'll look at perfusion of that lesion, and we see that the blue circle in the lesion demonstrates significantly more perfusion than a circle in green placed in the same region on the opposite side. And that's the green graph here. You remember there wasn't much enhancement, but you should also remember that malignant tumors that are anaplastic astrocytomas may not enhance. So, yes, 80% of malignant tumors will enhance. The 20% that don't enhance and are malignant are likely to be anaplastic astrocytomas. And the spectroscopy and perfusion support that. Finally, you can't make this up. These are both 24-year-olds. They're both male, and they both presented with seizures inside of the same week. These are right frontal lesions that look strikingly similar on FLAIR imaging. We're going to refer to them as case 6 and case 7. We'll look at case 6 first. T2 imaging coronal shows the lesion with some gyral signal adjacent to it. Not a whole lot in the way of enhancement with T1 imaging post-contrast. Definitely mass effect on the frontal horn of the lateral ventricle. We look at perfusion and we can't make much out of it being different from the contralateral side. 2.1 compared to 1.8, not significant. We'll turn to spectroscopy. Choline to creatine, looking about the way it should. NAA at 2 parts per million, not diminished. We're going to jump to K7 and then compare them. So this is the other patient, high right frontal lesion, same exact sequences, coronal T2, T1 with gadolinium, not a whole lot of enhancement. How about the perfusion? Again, very little help. The red graph is the lesion, 3.4. The green graph is the contralateral corresponding anatomy in the hemisphere, 3.2. Very little help. Let's again turn to spectroscopy. Now look at the choline membrane turnover relative to the creatine and the markedly diminished NAA. Here is their summary. Neither one demonstrated significant difference in perfusion. Case number 6 had a pretty normal spectral pattern in terms of the relative size of the peaks. Case number 7 did not. Membrane turnover, neuronal loss. You've come to probably the same conclusion that the pathology shows. Case 6 is an astrocytoma, a WHO grade 2. On MIB1 staining used to detect proliferation rate, there's only 3% proliferation demonstrated. Case number 7, on the other hand, is a mixed pathology oligoastrocytoma, a WHO grade 3, and the same stain, MIB1 staining, this time shows a 20% proliferation rate, consistent with the more malignant spectral pattern that we looked at together. I'll end with a quote from the person for whom my medical school is named, Albert Einstein. Logic, I hope we've shared some today, can get you from A to Z, but remember that imagination will get you everywhere. This is the coat of arms of Sir Moses Montefiore, for whom my hospital is named. His motto was think and thank. I thank you again for your attention today, and I'm happy to answer any questions.
Thank you so much, Dr. Bello, for that wonderful talk. And we are going to hold our questions until the end, so please make a note if you had any from Dr. Bello's talk. Our next speaker is Dr. Renato Mendonça, who, as well as being a luminary neuroradiologist from Brazil, is also the current president of the International Society of Radiology.
Good afternoon. Thank you for the opportunity to come to Egypt. Thank you for the organizers. Shukran. I'm going to try to show you in 25 minutes something about infections of the spine and of the spinal cord. As you saw in Dr. Bello presentations, we are very unspecific